Everybody hear me okay? Many years ago, I used to coach football, so if I'm too loud, then let me know. So this room has some really nice memories for me. My daughter had a reception here about 7 months ago, so pretty exciting. So my disclosures, I have to let everyone know that I'm an investigator on the Medtronic 670G study. It will apply to this talk because I'll be talking a little bit about the 670G. And the University of Michigan received financial support for that study. So here's what we're going to talk about. We're going to talk about basically how we manage kids with diabetes these days. We're going to talk about insulin pumps. We're going to talk about continuous glucose monitors. We're going to talk about the newest technology called hybrid closed loop, which is the first step toward the true artificial pancreas. And hopefully I can give you some really exciting thoughts about the very near future. So one of the things that has been very interesting is watching how our goals for children with type 1 diabetes have evolved. It turns out that in the United States, there may be a lot of reasons for this, but in the United States, our overall average control of our children's glycemia in the United States is probably a little bit worse in general than it is in Europe. And some of our European colleagues have said to us, you know, it's because you guys don't have low enough targets. Years ago, we actually used to have different hemoglobin A1C targets for the younger kids. We actually used to say, look, we really don't ever want to see an A1C below 7.5. That's too low for the younger kids. And it turns out now that if you look at this slide, it turns out that the newest guidelines is that anybody age 19 or below, we're actually having the same targets now. So every child, we're trying to aim for a fasting or preprandial glucose between 90 and 130, bedtime and overnight 90 to 150, postprandial 2 hours after a meal less than 180, and then hemoglobin A1C is less than 7.5. So no longer are we saying, look, it's not okay to be a little bit higher when you're young, but in fact, we're trying to get all the kids to the same general target. Young adults, A1C goal is less than 7%, slightly different fasting or preprandial goals. And of course, target goals for blood sugar control are always dependent upon the individual. If you have a 19-year-old truck driver, let's say, who can't appreciate his lows at all, well, that person you're going to aim a little bit higher, right? Because if that person has a major hypoglycemic reaction and can't feel it coming, that's a life-threatening situation. So even though we have these as our glucose goals for kids and for young adults, the reality is we need to be cognizant about the individual needs of the individual patient. So let's talk a minute about all the new insulins that are available. How many of you are in day-to-day practice of potentially of kids with, potentially might have a kid with diabetes in your practice? Okay, so at least half of you. So things have changed a lot. For those of you who trained when I did in the 80s and early 90s, we used to use NPH and regular insulin quite a bit. We basically don't use it almost ever anymore. And the reason is because those insulins were extremely variable in their absorption. And so we've moved toward these faster insulins at meals. Lispro is the same as Humalog. Aspart is Novolog. Glulisine is the same as Apidra. So those insulins work relatively quickly. They peak in an hour or two. They last maybe 4 to 6 hours. Fiasp is a brand new insulin. I don't believe it's approved for children yet, but it should be fairly soon. That's a faster insulin. It's called faster Novolog or Fiasp. This insulin is designed to be equally efficacious if given after the meal as if you were giving Novolog, say, 10 to 15 minutes before the meal. So it's that much faster. So we're going to start to see over the next year, I think, more and more studies with kids about using this, especially with the young kids. Imagine if you're a mother and you're trying to follow a toddler, and we always educate families, you know, you're supposed to give your insulin before you eat. 15 minutes, 10, 15 minutes before you eat. Well, let's say you give insulin to a 3-year-old and you count on a certain number of grams of carbohydrate. Imagine the horror and the terror if that child starts having a little temper tantrum and decides they don't want to eat anything. and you've already given that child a significant insulin dose. So this Fias might take that pressure away so that we can start to give insulin after the meal. Glargine, of course, is a once-a-day basal insulin, also called Lantus. Detamir is a similar but slightly different insulin from a different company. Degludec is this newest insulin, sort of a sister insulin to Detamir that lasts even longer. And this insulin, the nice thing about this insulin, it's also called Tresiba. It's a relatively new insulin, a little bit more expensive. But the nice thing about Degludec is that you don't have to give it the same time every day. So it's FDA approved to give it, you have to be at least 8 hours from the last dose. So if a child has got an extremely erratic schedule, you can give it one day at 5 o'clock, one day at 8 p.m., one day at noon, et cetera. So it actually works pretty well to give it at different times. So it's a really nice potential insulin for those people. So that's another of the basal insulin. So those the last three that I mentioned, Glargine, Detamir, and Degludec, those are all basal insulin. So generally you're using them once a day. Occasionally you have to use Detamir because its time action profile is not quite as long. We use it twice a day, but generally once a day for those last three insulins. So a couple of definitions. I know this is probably a review for almost everybody in the room who takes care of anybody with diabetes, but we really have moved toward what we call basal bolus therapy. So you need a background level of insulin in your body, and then you need insulin to handle the increased requirements when you eat. So basal insulin is the insulin level required to achieve an equilibrium between glucose production or gluconeogenesis and peripheral glucose disposal. All of you sitting there right now, even though you're not exercising, are actually burning sugar. And your liver is making just enough to match that. Okay, that's called basal insulin. So you need an insulin that's going to be continuous. If you're on injections, that insulin is given either Glargine or Detamir or Degludec once a day usually. That basal insulin, if you're on a pump, is delivered hourly. Well, it's actually delivered in fractions of an hour. Tiny little drips of insulin going in continuously around the whole day. Insulin to carbohydrate ratio is also called the insulin to carb ratio or carb ratio, is the amount of grams of carbohydrate per unit of insulin. Correction factor, this is the amount of insulin that is expected to cover a certain amount of blood sugar units. So for example, if your correction factor is 50, it means that 1 unit of Novolog or Humalog or Apidra should correct your sugar over about the next 4 hours by 50 points, okay? So the standard basal bolus therapy includes a daily insulin, again, Glargine, Detamir, or Degludec, and includes mealtime insulin, Humalog, Novolog, Apidra. The mealtime insulin is decided based on how much carb you're gonna have, based on your carb ratio, and then you add to that any additional insulin that you need to give for a correction of the current blood sugar. That's called the correction factor. Any questions about that? That's basically the summary of what we do. We try to think like a pancreas. This is basically a slide that shows you exactly what I just said. So this red line here is that once a day basal insulin that you need to provide that continuous level of support. Breakfast, lunch, dinner. You get a dose of insulin that matches your food intake plus any insulin you need to correct a high blood sugar. So this is what we do. Families, kids need to check their sugars frequently to do this. This is called intensive insulin management or basal bolus therapy. You need to be able to count and cover your carbohydrates. And again, we give extra insulin if you would need to correct hyperglycemia. So in kids, generally typical insulin doses are between 0.5 and 1 unit per kilogram per day. This is really important for you to know this range because if you're adjusting insulin in a child, say, on Glargine and Aspart, and let's say that child has increased their own dose up to 3 units per kilogram per day, what do you think is probably happening? The answer is he's probably not getting his insulin. My old boss in Boston used to say, you know, teenagers, yeah, they are insulin resistant, but they also have this thing called insulin resistance syndrome. They're resistant to taking their insulin, okay? So it's really helpful for the most part to know these guidelines in terms of how much typical insulin somebody needs because you just need to be aware that if your dose is going up and up and up, it's more often than not always, but more often than not that they're not actually getting it. Basal insulin, in my experience, usually 40 to 45% of the total. Bolus insulin, 55 to 60% of the total. So let's say a child is 20 kilos, you expect them to need 15 units a day, they're going to be on maybe 6 units of Lantus, and the rest of their insulin will be given as mealtime insulin. So that was describing basal bolus therapy with injections. Now we're going to transition and talk a little bit about insulin pump therapy. So an insulin pump is a fancy electronic device that delivers insulin. Okay, it's as simple as that. Kids can do very well on injections, but they sort of start to get tired of the number of injections that we're asking them to take. So insulin pump therapy alleviates that. They put the site in, which I'll show you in a minute. They do that generally once every 2 to 3 days. And the insulin is the basal insulin. Again, they're no longer on Lantus. They're no longer on a daily shot of long-lasting insulin. But the insulin pump is programmed to give them that daily insulin over short periods of time. So a child, say, for example, who might have been on 24 units of Lantus, now they're on a basal rate of 1 unit per hour. Does that make sense to everybody? So it's basically a conversion. Most of the time, kids maybe need a little bit less insulin on the pump than they do on injections, but it's generally pretty close. They have to check their sugar. It's really important. We're going to tell you some exciting new things in a minute about ways we can check our sugar. The most important thing on insulin pump therapy is to problem solve ketones. So the thing we didn't talk about yet is the way that the body makes ketones. So in situations where the insulin is not being delivered, whether it's a child who's on basal bolus therapy and injections and they miss their Lantus dose, or it's a child who's on a pump whose pump stops working or the pump site comes out. The most important thing for somebody on a pump is when their sugar is high, they must check ketones. So a combination of a high sugar and ketones on the pump means that your insulin level in your body is low and your liver has turned into a ketone producing factory. Okay, this is the biggest issue with pumps because no longer do they get that daily injection of long-lasting insulin to protect them from making ketones. If they have a bad pump or a bad pump site, if that site goes bad, all of a sudden they can start making ketones, and if they don't pay close attention, then they end up in the hospital in ketoacidosis. So it's really, really important that they understand that they're going to check their ketones if their sugar is high, and if they have a high blood sugar with ketones, they're going to take a needle shot and they're going to change out their pump site. Why a needle shot? You would think, oh, you can just change your pump site. Well, if it's actually a pump problem and you change the pump site, it's not going to work. So a very quick story about this. I had a gal who was a pumper, and she called me when she was on her graduation week from high school. She was in tears. She's in excellent control. She's from the west side of the state. She calls me in tears and says, my sugar is high and I'm feeling sick to my stomach and I have large ketones and I don't know what to do. So we talked about it, and I said, well, you probably just have a bad pump site. I said, but make sure you take an injection. So she took an injection for me, and by the way, where have you been this week? Oh, it's my graduation week. I'm out at the beach. Interesting. So she takes an injection for her high sugar with ketones. She calls me back in 2 hours. She says, I feel worse. My sugar is higher, my ketones are worse, and I'm ready to start vomiting. So where did you store your insulin while you've been at the beach? Her insulin was in the tent. Her insulin got cooked. So the point is that if you don't take a needle shot to correct a high sugar with ketones when you're on the pump, you're going to make a mistake because it might be bad insulin. So what we did for her is right near Ottawa Beach, there was a small pharmacy. We got her a new bottle of insulin. She took a shot, and a few hours later, she was feeling much better. She put in a new pump site, new insulin, et cetera. It was all fine. But her insulin got cooked in the tent. So the point is, high sugar on the pump, check your ketones, high sugar with ketones, take a shot, change your pump site. Really important to reinforce that with your patients when they're coming in to see you. What about discontinuing pump therapy? Well, this is always a challenge for us because most families don't want to discontinue the insulin pump therapy. The problem is if they have recurrent DKA because they're not managing well through those issues we just discussed, that's a problem. So sometimes we will take them off if they're not managing well. Intentional overdosing, actually, believe it or not, happens. I mean, we had a kid at camp last year who was doing this. She was giving herself extra boluses, lots of extra units, making herself below 40 all the time. We tried to figure out what was going on. We don't think she was clinically depressed, but we had to take her pump away for the rest of the camp week. And of course, if you have MRSA or some sort of recurrent site infection where if you put a site through your skin, you're going to get infected every time. Obviously, you can't be on a pump. So here was the first major pump, I would say, that I think had a lot of excellent features to it. The Medtronic Revel was the 523. It has this thing called a bolus wizard. You put the carb ratio, the correction factor in there. The child checks the sugar. It shows up on the pump. They can quickly correct the sugar at mealtime, and then they can add in the carbohydrates and figure out their bolus. This NextLink meter is really quite nice because you can plug it into a USB port and you can download all the data into the website for us to see or for the parents to see. Another pump, this is what's called a patch pump, which is a pump that doesn't have tubing. You can see where this pump is on this person's belly. You know what I notice is all these marketing slides always have people with incredibly flat stomachs, right? I mean, who looks like that? Anyway, so this Omnipod pump right here is a patch pump. It's controlled by this handheld device. It acts as the sugar meter and also the device where you can put the carbohydrates into the meal and it will calculate your dose for you. It is a nice pump in that it's waterproof, so you can swim with this pump on. That wasn't me, okay. Anyway, it's a good pump. It's the only current pump available in the market that doesn't have the tubing. I should have said, you can see here the insertion site in the abdomen on the Medtronic pump has the tubing here, and then there's a cartridge of insulin here in the pump itself. So this is the site that gets changed every 3 days. In the Omnipod, the pump itself gets changed every 2 to 3 days. So this is actually a disposable insulin pump, which I guess if you're thinking about being green, some people have concerns about that. But at the end of the day, some kids really want to be able to hide it well without the tubing. Another pump called the Animas Vibe, it was called the One Touch Ping. So this top one is called the One Touch Ping. It can be controlled by this blood sugar meter. It's a handheld device, so you could keep your ping in your pocket. Some of the kids really like that, not to have to take out their pump to dose themselves. This bottom here is the Animas Vibe, which is basically the same pump, but it's combined with a continuous glucose monitor that we'll talk about in a minute. The last major competitor pump we use a lot of is called the T-Slim, and the newest version of the T-Slim is called the X2. The T-Slim X2, you can see here, looks like an iPhone. It's programmable right on the screen. A lot of the adolescents love this pump. The one big challenge with this pump that we have is that when you check your sugar on a meter, information doesn't automatically go into the pump, so that number's not automatically in there. So the teenager actually has to put in the number where they check their sugar. Well, you can probably imagine when they're busy, we're ideally correcting everything above, say, 150 or 130. Oh, my blood sugar's 182, that's good enough. So what ends up happening is when we download these pumps in clinic, we notice a lot of the teenagers are missing a lot of the sugars entered into the pump because it's an extra step. Now, this company is going to work on this. They're going to have meters that transmit the information directly into the pump. But as far as a pump goes, it's an excellent pump. It's been very reliable, dependable. And they do have for our obese patients, they do have a pump that holds 450 units. So it's the only pump on the market that holds 450 units. So let's talk a bit about continuous glucose monitoring. So continuous glucose monitoring is not exactly the same as blood sugar monitoring. So this is the Medtronic version, but I could show you a picture of any of the different companies. The sensor goes into the subcutaneous, and you can see this sensor here communicates. This is the interstitial fluid in here. So this creates a current based upon what the sugar is, because that little fiber has on it glucose oxidase. Whenever the sugar touches that fiber, it creates an electrical current. So the sugar is transmitted then to a receiver, which can read out and tell you what your sugar is. Well, it's called a sensor glucose. It's not the same exactly as a blood glucose, okay? So the sensor gets put through the skin, the transmitter plugs into the sensor and sends the electric signal through the air to a receiver, and that receiver can either be an actual receiver or it can be a handheld smartphone, for example, or an iDevice like an iPod or an iPad. Who can benefit from CGM, from continuous glucose monitoring? Well, I think probably everybody, but these are the groups that we really focus in on. Kids who are having lots of low blood sugars, severe lows, as I mentioned before, people who can't feel their lows, called hypoglycemia unawareness. People who just want to get better control. They want more information about their sugars. And then finally, those parents who have young kids, for example, the young school kids, say first, second, third graders, the moms and dads love to be able to see the numbers on their phone while their child is at school. Very reassuring for them that everything's going fine. Benefits, we can figure out whether we made mistakes during the day. We can look retrospectively at the data to decide whether we need more basal insulin or whether we need more bolus insulin, more food coverage, more correction coverage, et cetera. The overnight control is better just because you can run a little tighter if you know that if your sugar's going low, you're gonna get awakened. So parents feel a lot more comfortable running the kids a little bit lower at night. Now, this is what I'd love to talk about. Things we learn from CGM you might not learn any other way. So I had a boy about 6 months ago whose sugar was spiking to 400 within 30 to 45 minutes after every breakfast. And I had his pump download and I'm seeing his insulin there, putting in a ton of carbohydrate. And I said, what are you eating at breakfast? You're taking all this incredible amounts of insulin, incredible amounts of carb. He said, well, I'm not particularly hungry in the morning. He was drinking a 2-liter of Mountain Dew at breakfast. So no surprise, his sugar was skyrocketing. As the insulin finally kicked in, the sugar basically was already being urinated out, so he was actually going high and then going low. It's what they call a shark tooth pattern. And there are certain types of foods that tend to spike your sugar very quickly, things like bread and bagels and toast and those kinds of things, waffles, Pop-Tarts. So we're able with CGM to see the kinetics of the way your sugar gets absorbed and how it compares to how your insulin gets absorbed. Pre-meal bolusing clearly makes a difference. Now, I mentioned at the beginning this new insulin called Fiasp that you can give after the meal. That's going to radically change this. But as far as we are concerned right now, the insulins that we have available need to be pre-meal. So here's the Dexcom G5 Mobile. This is the first, I would say, the first sensor system that really changed the world of people with diabetes. This is the receiver. This is how it looks when it's received on an iPhone. You get a number and then you get this arrow. The thing I put down in the lower right-hand corner here is how accurate these are. So this Dexcom G5 Mobile is pretty close to as accurate as a blood sugar meter. Even though it's interstitial fluid monitoring with all the caveats I mentioned, it is extremely accurate. And most importantly, it was the first system that was allowed, the FDA allowed, because of the accuracy, the FDA allows people to dose based upon the number. So a child, an adolescent at school, they check their number, it's 250 at lunch. They do not have to poke their finger. They simply can use the number that the CGM is giving them to do their blood sugar to do their sugar correction, which is absolutely fantastic. Now, one of the caveats about this system is it did need to be calibrated twice a day. Calibration means doing a finger check, a blood sugar check, and then putting the number into the system to calibrate the sensor. It's not going to be true very shortly as I talk to you in a minute. So the one caveat, two caveats I should say about this particular system is number one, when you're sleeping, if you're laying on it, it can give you a false low. So the suggestion is that if you get a low while you're sleeping, to confirm it with a finger poke. The second thing is people taking Tylenol get false readings on this device. That's not true with their newest one, but that is true with the G5 Mobile. This one, the G6 Mobile, which is the newest version of the G5, of course, is more accurate. And most importantly, no more finger sticks. It is calibrated out of the factory. You plug it in, you wear it, you get your data, you never have to poke your finger again, which the kids are extremely excited about, I can't tell you. This is the newest Medtronic system. The sensor is down here. It reads out to a smartphone as well. This system has some special technology built into it to do some predictive things for you, gives you a little bit more information about your control. However, this particular system does not replace finger pokes for dosing. The Libre, if those of you have heard about this, is a new system. It basically is competing at a little bit lower price. You can see here, it's like a little plastic disc that you put on your skin, and they recommend it on the arm. Anytime you want your number, you wave the system over your arm. So you can get your number anytime you want. The average person in the clinical studies gets their information about 20 times a day. So imagine getting all that data, instead of having to poke your finger 20 times a day, you can actually just wave this little device over the little spot 20 times a day, which is pretty cool. The one problem with this that I see with this system, we're prescribing a lot of this right now, is that this data does not get transmitted anywhere. You actually have to pull the data from it. In other words, the data doesn't go from the sensor to something. It's not going to give you any warning alarms. You have to gather the data yourself. Some kids actually prefer that. They prefer not to be alarmed at school or elsewhere. So, complaints can irritate your skin, can come off early. You know, at diabetes camp, we always find a few at the bottom of the lake. You know, it happens every year. I mentioned the false alarms when you're sleeping on it. So these arrows are very, very helpful. The arrows mean different things for different manufacturers. So one arrow up, for example, on the Dexcom means that it's rising, your number is rising at that moment 2 to 3 points per minute. One arrow up on the Medtronic is 1 to 2 per minute. So you need to know what your technology is and sort of how you can figure out how to deal with it. So we will often have families use the numbers real time based on their arrow up and down. For example, you can use the data to either adjust your dose upward or downward, and here's some examples of that you could use in your own practice. You can actually see a number, say, of 120 with 2 arrows down. You can predict when you're going to be low, and you can take a small snack before you get there. Extremely important to prevent lows rather than treat them. Okay, once you're low, your body turns on the hormone system to raise the sugar and you stay elevated for several hours. If you can start to use this tool to predict when you're going to go low, you can take a little bit of carbohydrate rather than a lot to prevent yourself from going low and prevent the hormone response to that. And this is how you might adjust insulin real time to decrease your insulin at the time of a meal. So a few words, I got a couple minutes left, a few words on the Medtronic systems. This system called the 530G was the first FDA-approved device that would take information from a sensor and do something with it. So this device would automatically turn off your insulin if your sugar was low. Okay, first one. This latest version, which is a study I mentioned at the beginning that we're part of, it's approved for age 14 plus. It's currently being reviewed in the FDA for age 7 to 13. It is probably going to be approved in the next few weeks. This particular device, you can see here, there's the sensor. The sensor sends a signal to the pump, and this is really important. The device will actually dose your insulin between meals based on what the sensor tells it. So all of a sudden now we have a system where if your sugar's going up at night, you get a little more insulin. If your sugar's going down at night, particularly in somebody who drinks alcohol, somebody who's been exercising, all of a sudden it turns down your insulin to keep your sugar flat. So this is now the path to the future, quite honestly. The Medtronic 670G is the world's first FDA-approved hybrid closed-loop system. Again, it doesn't take the place of the individual managing it. You still have to plug in your carbohydrates. You still have to poke your finger because this sensor is not FDA approved to do without calibrations. Remember I said at the beginning, Dexcom is without the newest Dexcom that's going to be shipping in a few weeks is without calibrations. The Freestyle Libre is without calibrations. This system still requires that you poke your finger and calibrate the system. I think that's probably going to change in the next year or two, but not yet. You can operate this pump, the 670G, in a manual mode, just like a current pump would be used. Or you operate it in this auto mode feature where the sensor and the pump are working together to adjust your insulin. This was some data that I gave at the Endocrine Society meeting. And this is a pretty busy slide, so I'm sorry about that. But what it basically shows is that all age groups responded well, improvement of A1C by about 0.5 percentage point. And there was no severe hypoglycemia. So how close are we to the artificial pancreas? The 670G is getting us closer and closer. We're still a ways away. We need maybe faster insulins that work much quicker to be able to keep up with food, because for the pump sensor combination to adjust your insulin fast enough to keep up with your food, it's going to have to be an ultra-fast insulin. The CGM accuracy is getting there. Like I said, 2 different devices now that you don't require finger pokes to calibrate the system. And then this was back in, say, 2013, a guy named Steve Russell out in Boston. He works at the Mass General. He predicted that by 2017, we would have a sensor accurate enough to control insulin delivery, and that's exactly what happened with the 670G, which was approved last year. All right, so that's my 30 minutes. I have about 5 minutes for questions, if anybody has any questions. Yeah.
Can you please go to the microphone? We just have to be a stickler about it so our off-site can hear you.
Could you comment about how to manage air in the tubing for insulin pumps, specifically the Medtronic?
Sure. So the question is how to manage air in the tubing. Well, one of the things that we find is that when people put cold insulin into a pump, is that as it gets warmer, you can get some tubing bubbles. So the first thing we try, if that's a consistent problem for them, is to use room temperature insulin. So you take your insulin out of the fridge, but once you make it room temperature, it's good for less time. So once you open it up, it's good for 30 days. If it's unopened and in the fridge, it's good till the expiration date. So you have to be aware of that. But we tell them first to put it at room temperature and see if that helps with the bubble problem. If that doesn't help with the bubble problem, I don't remember what our CDEs tell them beyond that, because typically that takes care of the issue of giving room temperature insulin into their pump. So, anybody else? Any other questions?
Does anybody have a written question? You didn't even mention inhaled insulin.
Okay, so the question is about inhaled insulin. So one of the problems with the initial inhaled insulins years and years ago is that a subset of patients develop pulmonary fibrosis. So insulin is a very potent growth hormone. For those of you who have seen a baby born to a poorly controlled mother with diabetes, the babies are like 12 pounds. Why? Because insulin is a very, very, very potent growth hormone. So when you inhale insulin, my biggest worry, my biggest fear is that a growing child, and I have never used it, nor will I ever use it until somebody does the studies for a decade or two in children. My biggest worry is you're going to develop a stiffening of the lungs. And you know what? We can manage diabetes as it is, but if you need a lung transplant, it's a big issue. So my biggest worry about inhaled insulin, and some adults use it, it's approved. I mean, that's fine. I don't know if I answered your question, but I will be the last one to use. I'm generally a pretty aggressive adopter of new stuff, but in the inhaled insulin world, I'm a little bit worried about the effects of insulin directly on the lung. It works, though. The other question is, Tylenol causes a falsely elevated glucose with CGM. Yes, so that is the G5, but the G6 does not have that. The Dexcom G6 Mobile does not have that interference. So Tylenol doesn't appear to be an issue with the newest sensor. Any other questions?
Just curious, as you talked about the increased data access for parents remotely and kind of continuously incoming data, wondering if you've got a subset of families that find this to be anxiety provoking or micromanaging?
Yes.
And how you respond to that from a family standpoint?
So the question is, what about those families that are hypervigilant and they love having that data? In fact, I just gave a nurse the nurse talk yesterday, Michigan State School Nurses Association. They asked the exact same question, and it's those moms that are calling them 10 times a day at school to say, "What happened to that blood sugar?" Here's our challenge. Our challenge is this happened before too. Even when you're poking your finger, we had a subset of kids where they're getting 20 to 30 finger pokes a day. So either way, we have to really try to rein in the families and teach them what the data can show them and how quickly they need to respond to it. And we try as best we can. We don't always succeed, but we try as best we can to get them to relax a little bit and understand that diabetes control is never perfect. We just have to live with some variability. So, okay, thank you very much.